Hey MedSurg students, in this presentation I'm going to review renal and urinary anatomy and physiology. First we're going to talk about kidney function and what the kidneys do for us to maintain homeostasis. You can remember kidney function by the mnemonic a wet bed. The kidney is basically a filter for our blood. Okay, so the first letter in the mnemonic is A for acid-base balance. Our kidney is trying to keep us in homeostasis. So it makes sure that the body isn't too acidic or too basic. Okay, so it keeps our pH in the normal range. W stands for water removal. The kidney, obviously, the kidney is involved in urination, making urine. So it helps us remove water from the body. E stands for erythropoiesis. So the kidney manufactures a hormone called erythropoietin. And erythropoietin stimulates the bone marrow to make red blood cells. Okay, and like say in times when your blood cells are low, you would secrete more erythropoietin if your kidney is working properly. T is for toxin removal. The kidney helps remove toxins such as urea and ammonia from the body, but also medications. It helps us clear medications. B is for blood pressure control. So the kidney helps us maintain blood pressure so that it's not too high or too low. E is for electrolyte balance. The kidney helps us maintain our electrolytes in the right normal range. And then D is for vitamin D activation. So the kidney helps us activate vitamin D in the body so that we can have strong bones and teeth. Our kidneys receive 20 to 25% of our cardiac output. So what that means is somebody, like say, has a dysrhythmia or they're in shock, their kidneys are not going to be perfused. That's why that's one of the assessment findings we always look for when somebody is having a low perfusion state. We want to know if the kidneys are being perfused, if they're putting out urine. So the kidney is also highly vascular. To give you an example, you don't have to memorize this or anything, but the renal artery, 1,200 mLs per minute of blood flows through the renal artery. That's per minute. So think of an IV bag. That's 1,000 mL. So add a little bit to that, and that's how much blood is going through your renal artery per minute, okay? And then the renal artery divides to form the efferent arteriole. And I promise we're not going to go that deep. I'm just going to show you a few things about the anatomy and physiology of the kidney. The nephron is the basic functional unit of the kidney. I promise I'm going to make this painless, okay? The glomerulus is in the center of the nephron, and Bowman's capsule is around the glomerulus. Now, the glomerulus is a network of capillaries, and it lets small molecules of water and waste products to pass through from the blood into the urine. It prevents the larger molecules, such as protein and red blood cells, from going into the urine. So you know if somebody has red blood cells or rusty colored urine or smoke colored urine, or if they have protein in their urine, you know that there's something wrong with the glomerulus or the kidney, okay? Urea and creatinine can also filter through the glomerulus, and that's a good thing because we don't want urea, like our BUN and creatinine, to get very high because we can become uremic, and I'm going to talk about that a little bit later. Glucose spills into the urine if the sugar is greater than 220 milligrams per deciliter, okay? Infiltrate, which is what filters through the glomerulus, blood, into the urine, okay, travels in the tubules and becomes urine, okay? So that was pretty painless, right? But you learned that you should not see large molecules in your urine, protein and red blood cells, okay? And that you should have a normal BUN and creatinine if the kidney's working properly. Okay, the glomerular filtration rate is the most accurate measure of kidney function. The normal is, and this is for young people, 125 mLs per minute. That's a normal glomerular filtration rate. It's mirrored in a lab test called the creatinine clearance, for which you have to do a 24-hour urine, and you know all the interventions from that because you learned about it last semester. It also is decreased in kidney disease. So the BUN and creatinine increase and the glomerular filtration rate decreases. And as you age, it decreases as well. The filtrate that filters through the glomerulus makes its way down the tubule system, okay, and becomes urine as is going through the tubule system. Now, I just want to tell you a few things about the distal tubule. You don't have to memorize them, but it secretes potassium for us because we lose potassium in our urine, and that's going to be important when we talk about kidney disease. It also secretes H ion, which means we lose hydrogen in our urine. And remember, that's acidic. So we lose acid in our urine, and ammonia. We also lose that in our urine. It helps us reabsorb water under the influence of ADH, antidiuretic hormone, and bicarb helps us reabsorb water and bicarb. So if we're not able to reabsorb water and bicarb, we could be dehydrated, we could become acidic, okay? Aldosterone helps us reabsorb sodium and excretes potassium. So if the distal tubule can no longer do this, you're going to have a high potassium. And then remember, parathyroid hormone is released when calcium is low because it helps make the calcium level increase. And that's due to tubular reabsorption of calcium in the body. And it decreases the reabsorption of phosphate. So anytime you're talking about calcium and phosphorus, they're opposite. They're opposing, right? Calcium's low, phosphate is high, and if phosphate is high, calcium is low. Now I'm going to take you through the wet bed again, but I'm going to go over the assessment findings if the kidney's not working, and also the nursing interventions that you would do for that assessment finding, okay? So as you recall, A stands for acid-base balance. So if the kidney can no longer secrete H ions into our urine, they're going to collect in the bloodstream and we're going to become acidotic. And that's metabolic acidosis. So a low pH and a low bicarb, okay? Your patient may develop Kussmaul's respirations to try to compensate for that metabolic acidosis by blowing off PaCO2, okay? The treatment for this would be hemodialysis or fix whatever kidney problem the patient is having, if that's even possible. W stands for water removal. If the kidney cannot help remove water from the body, your patient is going to have signs and symptoms of fluid overload. And this is very dangerous. And we worry about this the most, okay? So your patient can develop crackles, tachypnea, tachycardia, usually the first sign, shortness of breath, dyspnea on exertion. With pulmonary edema, they can develop pink frothy sputum, low O2 sat, and a soccer. That means all over body edema. Also, sometimes, you know, the skin under your eyes is like the weakest skin in your body, or it's not that tight. So if you're going to have like edema, sometimes the first time you'll see it is under your eyes. They'll be puffy. Feelings of impending doom. Anytime somebody has a low O2 sat or they're hypoxic, they could have feelings of impending doom. And vein distension, you know, like jugular vein distension, they could have that as well. First thing you're going to do is you find somebody short of breath and with pulmonary edema is you're going to get that head of the bed up, okay, before you put on oxygen. They may need furosemide if the patient is still making urine. Some people have kidney disease and they're anuric, meaning they have less than 100 mLs of urine output per day, or some people have no urine output per day, okay? So you wouldn't give furosemide to them because then that would stay in their body and it could lead to like hearing loss, right? You know, furosemide can be detrimental to your hearing. Morphine is a great drug for pulmonary edema. It helps relax people's breathing, anxiety, helps dilate the pulmonary vasculature. So it's a very good drug for pulmonary edema. Aminophylline, we don't really give that much anymore, but that helps dilate the bronchioles and helps them breathe better. Digitalis helps with the pumping of the heart so it can be more efficient. But keep in mind, if your patient has kidney disease, with all these drugs, they could become toxic from it because they have trouble removing the toxins from their body, okay? And then if they're not making urine, they're anuric, they'll have to have dialysis to get that fluid off. And when people have kidney disease, as it progresses, they do have to be on a fluid restriction. Okay, E is for erythropoiesis. I mentioned that the kidney manufactures erythropoietin, the hormone responsible for helping us stimulate red blood cell growth. So if our kidneys can no longer do this function of erythropoiesis, um, your patient's going to become anemic, okay? And remember, with anemia comes fatigue, pallor, and shortness of breath. And they could have behavior called pica, where they chew ice or other non-type foods, okay? The medicine for that is epoetin alpha. There are some nursing implications of that. For example, you would assess for a headache, hypertension. Patient could have an MI or a DVT due to epoetin, so you would monitor for all those. You want to encourage your patient to alternate rest with activity to manage the fatigue that comes with anemia. Oftentimes, like with renal patients, when they get epoetin and they start producing more blood cells, they start to feel a lot better and less fatigued. They become more interested in sex with their partners because they're feeling like they have more energy. So it's a really good drug for them. You just have to monitor for the side effects. Also, it has to be refrigerated, and you stop when the hemoglobin gets to 11. Okay, so if it's 11, you're probably going to call the provider and say, "Hey, do you still want me to give it?" Okay. T stands for toxin removal. So our kidneys help us get rid of urea and creatinine in our body. It helps us get rid of medication, right? They're eliminated by the kidneys. So people that have kidney disease are going to have high BUN and creatinines, which is going to cause uremia, which causes confusion. So we decrease protein in the diet to help with that. It's going to make their skin very itchy and have a sallow color. Sallow color is a yellowish tan gray undertone. Okay. And if you ever see somebody with renal failure, end-stage renal failure with that color, they kind of almost look tan sometimes. You'll never forget it. Okay. VAN, that's one of the earliest signs of uremia. It stands for vomiting, anorexia, and nausea. Uremia is toxic to our mucous membranes and also our serous membranes. So the patient could have stomatitis, which is, irritation inside the mouth and the mucous membranes. They can also develop ulcers, gastric ulcers, sorry, I should have said that. They could develop diarrhea due to irritation of the bowel, and pericarditis due to the irritation of the pericardium. And with medication toxicity, like, let me give you an example. Say, oftentimes, renal patients are also diabetics, and say they're taking insulin. You may have to start to check the blood sugars more because the insulin's going to more frequently, sorry, because the insulin's going to stay in their body longer. Okay, so keep that in mind. And they're taking digitalis, they can get toxic from that. So just keep that in mind, that they can get toxic from drugs. B stands for blood pressure control. And this is kind of a chicken and egg situation because having uncontrolled hypertension is probably one of the main drivers of kidney disease. But also kidney disease causes high blood pressure. So patients with kidney disease need very good hypertension management. Oftentimes they're put on an ACE inhibitor early to decrease protein loss in the urine, and also help with blood pressure. They can be prescribed calcium channel blockers and beta blockers as well. Just a note of caution, those that are prescribed ACE inhibitors and ARBs, those can increase potassium in the body, which also happens with kidney disease. So it can also, when it's given to patients with kidney disease, increase the potassium further. So watch for that. Okay, for electrolyte imbalances, this is like, there's going to be a lot of electrolyte balances if somebody has kidney disease, because the kidney cannot no longer remove potassium through the urine, okay? So the patient is going to have a high potassium, and they're going to suffer from dysrhythmias because of this. So you always want a patient with kidney disease and a high potassium to be on a monitor. They're going to have high phosphate levels and low calcium levels. And this is going to lead to osteodystrophy, which means patients with long-term end-stage renal disease, they could like break a bone just by hitting their hand on, like, say, the bedside rail, okay? That's how weak their bones become over time. And then with magnesium, we worry about, heart problems as well. And we need to be on a low sodium diet for people with kidney disease as it progresses. For high potassium, remember the mnemonic kind. So Kayexalate can be given, which is also called polystyrene sulfonate, which is probably on your exams. And insulin and dextrose helps drive potassium in the cells. Bicarb as well. You never want to give patients with high potassium salt substitutes because they're high in potassium. And then they may need to have dialysis if they're not making urine, if they're not producing urine anymore. But if they are producing urine, they may get diuretics to help with that. For high phosphate, they're going to take phosphor binders with all meals, so Celavir, or aluminum-based antacids. And they need to avoid high phosphorus foods like dairy, soda, nuts, okay? Low calcium, encourage calcium in the diet. They may take vitamin D3, that will help with the calcium absorption. And then for high magnesium, avoid giving magnesium containing antacids such as Milkamag. So vitamin D is also going to be low, which is going to result in low calcium. And your patient can develop osteodystrophy, which I talked about. So they're going to need vitamin D3 supplementation. Okay, one more time, just look this over one more time. A wet bed tells us what the kidney is supposed to do. If the patient has kidney disease, they're going to get the conditions that are in the parentheses, okay? I really want you to take some time and reflect on this, because if you can learn this, and when we get into kidney diseases, it's going to be like, oh yeah, of course that would happen if the kidney's not working properly. Okay, so it's really important that you reflect on this. Okay, the urinary system. So each kidney, attached to each kidney is a ureter about 9 inches long, okay? The bladder, and it attaches to the bladder, which is a muscular organ, hollow muscular organ, which holds our urine, about 500 mLs. And if you just look real quick here, you notice that the female has a shorter urethra, which is why we're more prone to urinary tract infections, because the bacteria doesn't have that long to go, right, to infect us. Whereas if you look at the male urethra, it's a lot longer. I know you learned about urinalysis last semester, but we're going to just review it again. So a normal urinalysis has a pH of 4.5 to 8. If it's high, it could mean there's bacteria in the urine. You should not have bacteria in your urine. If you do, you probably have an infection. You should not have leukocyte esterase in your urine. Leukocyte esterase is secreted from white blood cells, and it lets us know that your patient does have a urinary tract infection if it is present. WBCs should be less than 5. Nitrates should be absent. Nitrates are secreted from E. coli, so that definitely means you probably have an infection, right? RBC should be less than 5 if if the urine is bloody or rusty or has more RBCs, the patient might have a problem with their glomerulus. Protein should be negative, ketones should be negative, and glucose should be negative. I talked about glucose spilling into the urine when it's over 220. Ketones would be positive if somebody was like breaking down fat in their body for nutrition. And then protein would be positive if there's something wrong with the kidney and it's letting protein leak through the urine. When you're getting a UA, it's best if you can do early morning if you can, but it really can be done anytime. Remember, it's a midstream, so they urinate a little bit, then they clean, then they go into the cup, okay? And it needs to be in the refrigerator if it's going to be, it can't be standing for longer than an hour. Okay, specific gravity it's a measure of the solutes in the urine. Okay, so if the specific gravity is towards the low end, it's more like water, and if it's towards the high end, it's got a lot of solutes in it. Okay, so the normal range is 1.005 to 1.030. Water is 1.000. So it measures the concentration of urine. That's what I talked about. And it will be high in situations where there's dehydration. And if there's glucose in the urine, it could be high. If somebody has SIADH, which is opposite of what you would think, right? Because they're not dehydrated. But this is the one instance that it would be high without dehydration, okay? If the specific gravity is low, it could be because your patient has DI and the urine looks just like water, okay? So the urinary output would be low. People on diuretics, if you have a high calcium, so hypercalcemia, it causes a nephrotoxic diabetes insipidus. That's why people with hypercalcemia have a large urinary output. Low potassium does the same thing. If the specific gravity doesn't change, and it's like 10-10, we call it, fixed, it means your patient has kidney disease. They can no longer concentrate the urine. So they have what's called a fixed specific gravity. All right, with the creatinine clearance, I had talked about this is what mirrors the glomerular filtration rate, okay? The normal is 70 to 120 milliliters per minute, which is very close to the GFR, right? The only way you can measure it accurately is to get a 24-hour urine. Remember that you have to go to the lab and get the big jug, put it in ice, put signs up in the room. The patient voids, you discard the first urine, and then you collect all the urine for the next 24 hours. And then you do the last urine at the end, okay? And remember, if you miss one urine, you have to start all over again, okay? And typically what happens is after you collect the urine, the serum creatinine is also drawn to compare. But yeah, just remember the nursing implications. Okay, the BUN is a value we do look at if somebody has renal failure. However, the creatinine is always going to be more accurate than the BUN if you get asked, because there is a lot of reasons a BUN could be high without renal problems. So the normal is 10 to 20. It increases with patients with renal problems, but also if there are non-renal causes, like maybe you're on a ketone diet and you're eating a lot of protein. Okay, that can increase your BUN. If somebody has GI bleeding, that could increase the BUN because your body is going to digest blood in the GI tract as a protein. Dehydration causes a high BUN, and muscle breakdown also causes a high BUN. The creatinine is the most specific lab for renal function because it's released in your body at a constant rate. So, kidney disease is really the only reason somebody would have a bump in their creatinine. The normal is zero point 0.6 to 1.2. And high creatinine, indicates kidney disease. All right, we're going to talk about some tests now. Now, biopsy is the most definitive way to, figure out what's going on with the kidney, and it determines the cause of kidney disease. Like, say you had a patient that had an AKI or glomerulonephritis, and they don't know what's going on. They can do a kidney biopsy to determine what's going on with the kidney. Maybe they'll use contrast dye. I'm going to talk about contrast dye a little bit later, and you probably already know that that's damaging to the kidneys. Your patient needs to be NPO 4 to 6 hours before the procedure. You got to get the informed consent. You need to do the timeout, and make sure you do the pre-procedure checklist. Your patient is going to need coagulation studies because remember earlier I talked about how vascular the kidney is. So you can imagine if you put a huge needle in somebody's kidney, they could hemorrhage, okay? So you do the coagulation studies beforehand. And when I say coagulation studies, I mean the APTT, the PT, the INR, the platelets, okay? Because they're going to be at risk for bleeding. You position the patient prone. You can put like a pillow under their shoulders or their abdomen for comfort. When the provider is inserting the needle, you have the patient hold their breath, and this is to prevent a pneumothorax, okay? You don't want the patient to breathe while the provider's piercing the kidney. Okay, post-procedure, post-kidney biopsy procedure, you want to prevent hemorrhage, okay? Remember, the kidney's highly vascular. So you're going to do your post-procedural vital signs because if the patient does start to hemorrhage, you're going to see tachycardia first, then tachypnea, then finally a low blood pressure happens a little bit later, okay? They're going to have a narrowed pulse pressure. You're going to hold pressure times 20 minutes. And don't forget what the frequency of the post-procedural vital signs are. Q4 times 15 minutes, Q2 times 30 minutes, and Q 1 hour times 4, okay? You're going to put pressure on the puncture site for 20 minutes, and they'll put like a pressure dressing on it. I don't know if you've ever seen elastic type dressings that they put on for pressure dressings, but that's the kind they'll have on. Monitor for hematuria, monitor the dressing, make sure it's not getting saturated, monitor for pain. If your patient starts to complain, they're going to have pain. I mean, obviously, they put a needle in their back, right, in their flank. If they have radiation around to their back or their front, okay, or radiates anywhere, they may have a hemorrhage. So you're going to watch out for that. They're going to need to be on bed rest for up to 24 hours. So you want to keep them quiet. Now the kidney, fortunately, has a big capsule, a fibrous capsule that surrounds it with fat to protect it. So what you're trying to do is let that fibrous capsule tamponade the bleeding. So that's why you don't want your patient moving around and making a lot of gestures, okay? Coughing, sneezing, whatever. You want them quiet. Keep them quiet. Monitor for a UTI, which can happen about 72 hours later, and I think you know what the signs and symptoms of that are by now. Okay, a KUB is just a plain x-ray. It's a plain film. It stands for kidney, ureter, and bladder. And as you can see the kidneys in this picture, but they may do it like if somebody has like renal stones, or maybe somebody has an intestinal obstruction, okay? So it may be used to measure kidney size. The nursing implications include no jewelry and no pregnancy. Definitely, okay, before having a KUB. Okay, with the CAT scan, they can do this to determine kidney size, to assess the blood flow to the kidney. Typically, it's done with contrast media. So we have to talk about that because, the IV dye, it is toxic to the kidneys, all right? So you always, even if your patient doesn't have kidney damage, check the BUN and creatinine before somebody has a test with contrast dye. You hold metformin 24 hours before, 48 hours after. A test with contrast dye because you're trying to prevent lactic acidosis and renal failure in your patient. Okay. When the contrast is injected, you have to warn your patient that it's unbelievable. I just had a CAT scan. That's why I remember this. Um, the IV contrast makes you feel warm inside, but it goes in a sequence, like it starts in your throat and then travels down to your chest and all the way down your body to your pelvis. I mean, it's just crazy how it feels. You get this warm feeling. Um, check their urine output. They need to be putting out urine if they have contrast dye. They're going to give them normal saline, which is good flushing fluid to flush out all the dye and make sure that their kidneys are being perfused. No jewelry, obviously, before a CAT scan. So the interventions are pretty telling. The other thing too is with a CAT scan contrast medium, it does contain iodine. So ask if they have an allergy to shellfish. They may want to give them some medication to prevent a reaction beforehand. A renal scan is another test that can determine renal perfusion and the glomerular filtration rate. It's a test that's done in nuclear medicine. The patient is injected with a radioactive isotope. They're not going to be radioactive after the procedure, so you don't need to worry about that. It's a good test for people that have renal insufficiency because you don't have to worry about contrast dye. Um, and they may get captopril, which you probably figured out is an ACE inhibitor during the test. So you would have to monitor for like orthostatic hypotension during and after the test, and tell them all the things like rise slowly. All those safety precautions you need to do for somebody that is on blood pressure medication. The voiding cystourethrogram. This will be done in patients when they suspect they have reflux of urine from the bladder into the ureters. So contrast dye is infused through an intermittent, like a straight catheter, and they fill up the bladder with contrast dye. Then they take the straight cath out, and while the patient is voiding, they take the x-rays to see if there's reflux. The trick question usually is about the contrast dye. In this case, you don't need to worry about the BUN and creatinine because the contrast never leaves the bladder. So it doesn't enter the bloodstream or reach the kidney. So you don't have to worry about lactic acidosis and kidney damage. So the IV pileogram is looking at the renal pelvis for structural disorders. And so some of the nursing interventions include NPO after midnight. They do have contrast medium, and it does go in the bloodstream, okay, with this. Laxatives. They got to clear out the bowel, and typically they get an enema before they have the test. And they do use IV contrast. So all those interventions we talked about earlier, like holding metformin, giving fluids, checking the BUN and creatinine, you would do that for somebody with a retrograde IV pileogram test. Okay, that was pretty quick, painless. If you have any questions, let me know. And try to reflect on the wet bed and what the kidney's supposed to do and what happens when it can no longer function the way it's supposed to.